Hey, you guys, it's Sue. And first I have to say, isn't this a great template? I don't know why I'm feeling kind of groovy today, and this is looking kind of groovy today. So I promised you earlier in the week, you know what? I hate my face here. You can see my COVID waking. I need to somehow disguise that. Maybe I'll wear a scarf next time. I promised you that I would give you the answers to those case studies I posted for you, right? The ones that were just the description of the situation. I hope you worked on them. But as I go through this, I'll pause just for a second on the slides that say the questions if you want to stop and work on them again, and then restart as we get to the answers. So there's just 4 cases, but I think they're interesting, and tell me what you think. Here we go. Patient number 1. This is a 75-year-old man brought to the ER by his family, extremely short of breath, speaking in one-word sentences. Do you remember what I talked about that? A one-word sentence would mean that the patient can say only one word between breaths. And so that's a way that we communicate. The patient's using all of their accessory muscles to breathe. So you're going to see them lifting up. You're going to see the trapezius muscle really pulling. You're going to see nasal flaring, all of that. And it has a medical history of COPD. And this is where we always cue in COPD, oxygen. Are they a CO2 retainer? And we're going to go from there. We're always cueing to that, but also remember I told you not all patients fall within that subset, and we need to be able to understand whether this patient does or not. The history of worsening breathing over the past 3 days with increased volumes of sputum, right? So coughing up a lot more sputum. On exam, markedly increased work of breathing, and that work of breathing, remember I told you that respiratory therapists have a chemical equation for work of breathing. When we're discussing work of breathing, it's that increased use of accessory muscles, how many sentences they can speak, how much effort is it taking them to get to whatever sat they have. It's not just the saturation level that you're getting, it's how much effort is it taking. Remember I told you that like really classic language, are they about to poop out, right? Like they're just using all their work and they're going to fall off the cliff. Also with this patient, we see signs of hyperinflation of their chest and they have pursed lip breathing, classic COPD. So that didn't just happen today. That's what we would expect. They have breath sounds that are generally diminished throughout, but no adventitious sounds, right? So we're not hearing wheezing or anything else. We've got a set of vital signs here. We've got a temp of 36, a heart rate of 120, a respiratory rate of 26, blood pressure 150/80, and an O2 sat of 81. So no fever, the person is tachycardic and tachypnic, and those can go hand in hand in terms of being tachypnic and you're using so much effort. This massive effort to breathe can result in that tachycardia. Additionally, we have that low oxygen saturation, right? 81%. And do you remember what the expectation is? So 90 is where we fall off that curve, that oxyhemoglobin attraction dissociation curve, where we fall off and we have profoundly diminished levels of oxygen within those hemoglobin molecules. So, so 90 is the absolute minimum we typically accept, but we want it to be 95 and above. Ideal is 95 and above. So at 81, he is profoundly hypoxic. We've got some ABG results and some lab results. So we've got the hydrogen at 39.5. And remember, normally we fall between 35 and 45. pH is 7.4, so right in the middle there. We've got a PCO2 of 36, a little bit hard to follow that trail of numbers, but PCO2 of 36, and remember 35 to 45 is normal. We've got a PO2 of 44, and the normal is above 80, right? So a PO2 of 44, profoundly hypoxic, and a bicarb of 23, normal is 22 to 28. So the only thing that we see really out of order there is what? It's the PO2. Everything else is falling within norms, right? We also have some electrolytes, potassium of 4.1, and you've got your norm there. Sodium of 137, you've got your norm there, and a chloride of 99, you've got your norm there. All of those are falling within normal range. So the questions were: 1, can you analyze his ABGs and describe his acid-base status? And do you see how it's so much more important to do this within the context of a patient story than just where I see a set of ABGs? And then the big question, remember, this is a really big one for clinical practice. Should you provide him with supplemental oxygen and give your rationale? So his O2 sat's 81. He's got a long history of COPD. He's got physical manifestations of that, right? Classic, that hyperinflation, pursed lip breathing. His O2 sat is 81 with a PO2 on ABGs of 44. Is he a CO2 retainer? How could we tell? Should we give this gentleman oxygen? And remember, we're in high acuity. And is there something magical about 2 liters? Remember, does that mean we give 2 liters? So let's just think about this for a minute. If you haven't yet thought about this, I'm gonna suggest you pause and even go back a bit and look at those numbers again. You also have them in a Word doc. Analyze those ABGs, describe his acid-base status, and then make a determination. Should you provide him with supplemental oxygen, and give your rationale? Okay, and let's go on. So his ABGs, he has normal acid-base balance. Remember, everything was normal. pH fell within norm, other things, but he's got that respiratory impairment as indicated by the low oxygen. So his acid-base balance, remarkably, even though he's got COPD and he's so hypoxic with that low PO2, his acid-base balance is normal. So should we give him supplemental oxygen? This is so important. He has no indication that he's going to rely on hypoxic drive. And remember that only a portion of COPD patients have that kind of impairment. So in this case, look at his CO2. Even though his O2 was so low, his CO2 is normal and his bicarb was normal. So you know what? We need to give him oxygen. And don't assume that 2 liters is magical, right? We need to give him oxygen to SATs or ABGs that indicate adequate oxygenation. And so adequate in the absence of symptoms requiring anything greater, typically 90 with an ideal of 95. So do you get that? We looked at, now you are not doing this alone. You require an order. You're going to be working as, early in your career with those orders. We never leave anyone with an O2 sat of 81. But in this case, as we are applying oxygen, and if I'm wondering, should I follow that order? Because remember, every time I have a medical order, I am required to determine, should I follow that order or not? Is that order legitimate or not? If I was determining, is that order, let's say somebody orders Ventimask at 40%, should I provide that oxygen or not? I look at those ABGs and I see no indication that he's relying on hypoxic drive because his CO2 is normal and his bicarb is normal. His pH balance is normal. He is merely hypoxic. So he does not, there's no indication he falls into that subcategory of COPD patients who are CO2 retainers and who rely then on that hypoxic drive. Does that make sense? That we can actually look at those ABGs for clues to that. Regardless, we would make sure that a patient who is requiring adequate oxygenation is provided with that, but we may make determinations of how we do that and or if we are going to be likely having to intubate a patient. But do you see how we made a determination here based on a full understanding of his history, a physical exam, analyzing the full set of ABGs and seeing where that falls, making a determination. So now let's look at another patient. Now we've got a 68-year-old patient with COPD and sent by his family doc to the ER. History of increased breathlessness and reduced effort tolerance. That means that he gets increasingly short of breath by doing things he would normally be able to do. And so in this case, he's normally able to walk, I think that says 500 meters behind me, but now he has a lot of difficulty even getting himself dressed and even sitting completely at rest, he's short of breath. On exam, we see that he's awake and he's alert, he's mildly distressed. He's using those accessory muscles to breathe and he's using pursed lip breathing. Chest exam reveals that he's got hyperinflation, diminished breath sounds throughout, a little bit of wheezing, some scattered wheezes. And here we have some vital signs. Temp is 37. He's got a heart rate of 96, blood pressure of 138/82, O2 sat of 78. I don't have a respiratory rate. That's crap, right? That's not a full set of vital signs. That's ridiculous. Nobody's ever, often respiratory rate is not respected enough. Here we've got a patient who's already short of breath. That is ridiculous. In effect, his respiratory rate is 26. So this patient in lots of ways is similar to the patient we just looked at, isn't it? Hyperinflation, pursed lip breathing, shortness of breath. This one has a little bit of scattered wheezes, but in many ways quite similar. So because he's got some wheezes, he's treated with bronchodilators by nebulizer. Now, just to keep in mind, we know, so if you're using a bronchodilator like Ventolin, in the old days, and you still see it in emergency, that somebody puts it by mask and they aerosolize it and you see all that mist coming out and it looks like it's really having an impact. But to be honest, we know that actually the particles in an aerochambered PDI version of Ventolin are actually smaller, and they're able to get down further into our lungs, and they're much more effective. So it actually, even though in this situation we've given him nebulized bronchodilators, and that may be for a reason, it is typically more effective to give puffers. We can give them up to 1 puff every minute, up to 10 puffs over a short period of time. So that has an impact. When somebody is incredibly short of breath, though, and using all that, their accessory muscles to breathe and other things, sometimes we give the medication nebulized just because they're not able to take that deep inspiration to be able to try to get those little particles down. They give him, in addition to that bronchodilator, some oral prednisone. Remember that we're going to give a corticosteroid for that inflammatory response that is part of the asthma, or part of asthma and COPD. And they gave him 60% oxygen by face mask. Remember, his O2 sat was pretty low. It was 78. So his PO2 is going to be probably really low when we look at it. So they've done these treatments and his oxygen saturations are improving significantly. But when I go back to check him again in an hour, his condition has deteriorated so much that he's unable to give you any history, tell you anything. So now let's do the exam again. He's drowsy, difficult to rouse. He no longer shows any sign of respiratory distress. In fact, his respiratory rate is 14, but his chest exam is unchanged. I still see some scattered wheezes and diminished breath sounds. His temp is still 37. His heart rate's come down a little bit. It's 88. His respiratory rate's 14. Blood pressure is roughly the same, 132 on 80. And his O2 sat is 96. So just looking at those vital signs, if I had no context, I might say that's okay. That's a pretty good set of vital signs, right? Everything's kind of fallen within fairly norm. It's pretty good. Well, it's not really good. Look at my patient. My patient has changed dramatically. Remember, he was acutely distressed when he came in. We've given him nebulized bronchodilators, oral prednisone, and a lot of oxygen. His oxygen sats have come up beautifully. Look at his O2 sat. It's 96%. But now I can't wake him up. So what's happening here? Let's look at his ABGs now. So we take the ABGs not at the very beginning. We're taking them now that we find him difficult to rouse. Hydrogen 50.8. Where is that? Right above norm. pH 7.29. Where is that? Well below norm. PCO2 65. Well above norm. PO2 84. Beautiful. He's getting so much oxygen. Lucky him. Well into norm. We're happy with that, are we? And his bicarb is 30. It's up, right? Now we'll look at our electrolytes. They're all fine. So what's going on here? Hydrogen above norm. pH below norm. PCO2 well above norm. Remember, we're always looking, is someone a CO2 retainer? PCO2 well above norm. PO2, now I've just fixed the PO2 problem. Have I done anything to help with all the rest of these things, right? Bicarb up. So big question here, what's going on? What's going on with this patient? And this is the scenario, I know you've guessed it. This is the scenario we always warn you about. Acute on chronic respiratory impairment. So he has a chronic respiratory impairment and an acute on top of it, right? So he's got that acute COPD exacerbation on top of his chronic illness. And these ABGs show partially compensated respiratory acidosis. And so we can tell the difference because his pH is low and his PCO2 is high and his bicarb is high. And so this is the kind of patient, COPD patient, who's going to poop out and stop breathing, right? We've given him so much oxygen. His PO2 is great, but everything else is so aligned because he's relying on that hypoxic drive. So to breathe, it's the lower oxygen that makes him breathe, as opposed to a patient who typically would rely on their CO2 level to breathe. So his brain should be responding to that, has now become responsive to hypoxia as their stimulus to breathe. Now we've given him so much oxygen, he no longer has that stimulus to breathe. And so remember, how do we know the difference? Look at those ABGs again. We should have done those ABGs immediately on arrival, right? Remember that first patient, we did some ABGs before we did a whole bunch of interventions. And those first set of ABGs told us it was safe to give him oxygen because there were no signs of hypoxic drive, right? There were no signs that it was a CO2 retainer. In this case, had we done an initial set of ABGs on this patient, this is what we would have seen. pH 7.36. What does that look like? Normal, falls within normal, just normal, falls within normal. PCO2 54.1, right? So we already see CO2 retainer. We would have seen that high CO2, and the PO2 was 40, so profoundly low PO2. So ABGs prior to treatment would have shown that elevated PCO2. Sorry about that. They would have showed that elevated CO2 and the associated elevated bicarb, but with a normal pH. So that tells you that he would have had a fully compensated respiratory acidosis. That's how he lives. He lives with a fully compensated respiratory acidosis. And because it's fully compensated and we see that elevated bicarb in particular, and what you've learned about compensation is that renal compensation takes a while. We'll talk about this a little bit more later, I'm sure. That tells us it's chronic because it takes a long time for the kidneys to kick in, right? So what happened here and what we should have done, what should we have done? By giving him too much oxygen, this is the worst case scenario we always warn you about. Likely to see this on the NCLEX. But remember, the first guy is entirely different. Their story sounds the same, but they're different because their ABGs look different. We gave him too much oxygen, we suppressed that respiratory drive, and now he's at really profound risk for respiratory failure. We're going to take him to ICU. We're going to put BiPAP on him, and sort of because BiPAP is going to sort of push that oxygen in. Hopefully, we won't have to intubate this patient. It'll be very difficult to get that patient off the vent if we do. Bottom line here, we say this over and over, not all patients with COPD are the same. We cannot treat them the same. Initial baseline of those patients who have COPD and are acutely short of breath requires ABGs. All right, just make sure that we've got a set of ABGs, not just that O2 sat. All right, we need that full set of ABGs to understand that what the underlying condition of that patient in. And also just an important point that we shouldn't be using nasal prongs with patients who have COPD because that actual concentration of oxygen is not nearly as precise as using something more accurate, for example, I don't know, a venti mask or something. And this is, I mentioned this last week, UK guidelines have a target saturation for patients with COPD, typically of 88 to 92. Remember, under ideal circumstances, patients should have an O2 set of 95 and above. For patients with COPD in the UK, they're setting it at 88 to 92. And they're using these oxygen alert cards for patients who are CO2 retainers, right? And so they give an actual percentage to set the Venturi mask or the Venti mask to achieve their oxygen saturation and the range, and that would be completed by the respirologist. Also important to recognize that you can use compressed air to drive those nebulizers. And then, so you'd have, let's say you'd have your nasal oxygen and compressed air for a nebulizer, as opposed to having that nebulizer run on the full oxygen. And then it also says limit oxygen-driven nebulizers to 6 minutes. So really important trend towards patient safety. Oh my gosh, let's go to a new patient. This one I think is so fascinating. Well, they're all fascinating, aren't they? Oh my gosh, how do we get so lucky that this is what we get to talk about every day? 36-year-old pregnant woman. She's on the maternity ward. She complains of feeling short of breath. She has no other symptoms, no other relevant history. Why do we care? What would we think about a patient who's pregnant, who's very short of breath? We're always thinking patients who are pregnant PE, right? Thinking of PE. They can easily throw a clot, an amniotic clot. Now, on exam, patient is heavily pregnant. I must say these are not my case studies. I wish I was so brilliant and wrote them because I do love them. For a pregnant woman, I don't think it's ever fair to say the word heavy. But anyways, patient is very pregnant, but otherwise appears well. Chest looks fine, no abnormalities. We've got a set of vital signs. What do we have? 36.6, 110, 20, 112 over 90. First of all, I don't have an O2 sat. That's crap, right? Not acceptable. And secondly, I've got a little tachycardia, but nothing that looks compensatory particularly, right? So what might that be? If I see no compensation and it's just mild, that might tell me, like I'm not seeing anything that's alarming, but I've got a heart rate of 110. I'd sure pay attention to that. I would also wonder if you're anxious, and your heart rate went up a little bit, but everything else is within normal range. Is it okay? The blood pressure, we might see, that there's a diastolic rate of 90 is, or a number of 90 is a little bit high, but anyways, let's just keep an eye on things. Let's look at the ABG and lab results. So hydrogen, 35. Okay, right? pH, 7.45. Okay. PCO2 numbers running together, but it's 35 there. All right. PO2, 35, right? Remember, it should be above 80. What? PO2 of 35. And bicarb perfectly normal of 24. So everything there is all perfectly normal, but this is telling me she's got a PO2 of 35. PO2 of 35. How do you think someone would look if they had a PO2 of 35? She says she's feeling short of breath, no symptoms, nothing else on exam. Appears well. Does that make sense? Everything else is normal, just this dramatically low PO2. Electrolytes all look fine. Like, what the heck, right? You see something looks amiss here? Wait a second, even if I had a clot or something else, if the PO2 was so low that it was 35, why would I not see even like anything else, any compensation that's telling me what's going on? Everything is fine. Acid-base balance is perfectly fine. So let's look at that. I want you to take a second, describe her acid-base status and what could be causing that low PO2. That low PO2 in the absence of any other changes within her ABGs and any physical findings. So she looks well, but she's got a PO2 of 35. So what's going on? She's got a normal acid-base balance status with severe hypoxia. Remember, it should be above 80 and we're at 35, right? See, it doesn't make sense because everything else is normal, and it can't be normal because the human body has those magnificent compensatory mechanisms and they would kick in, right? It's not normal. So what's the explanation? Guess what? This is an arterial blood gas. In doing that arterial stab, they've got venous blood instead of arterial blood. And that patient's totally fine. We've got a venous sample. Now, what that tells you is a venous sample is fantastic for telling us pH. It tells us pH, tells us a lot of things. It can't tell us about PO2 because we've already deposited that oxygen, right? If the arteries carry that oxygenated blood away from the heart, but the veins return that deoxygenated blood, right? So and we don't know where exactly in this, along that route this blood is. So the oxygen, the PO2 is meaningless because this is venous blood. We don't take venous blood gases for anything except typically we're looking at that pH, and it still will give me a good measure of that pH. All right, so what we would say is that sample is not it's not an accurate sample. It's a venous sample. So important. What if we started treating? Start pouring oxygen into her. Well, first of all, an O2 sat should be done, and that O2 sat should be some indication, right? But also, it just doesn't make sense with how she's presenting. She looks perfectly fine. Oh my gosh! Shall we carry on to the last one? Here we go. Here we are with patient number 4. 35-year-old female brought to the ER by ambulance after being found in her home unconscious by her 10-year-old daughter when she returned home from school. She's got a recent history of stomach upset, according to the patient's daughter. On exam, she's drowsy and she's peripherally shut down, right? So peripherally shut down means that I really don't see veins. I've got slow capillary refill. Very, very dry mucous membranes. Respirations are deep and sighing, and she has a funny odor. Funny odor, so important. Important in millions of situations, important in this situation. Let's look at our set of vitals. 36.9, tachycardic at 130, tachypnic at 26, and we already know they're deep and sighing. When we are tachypnic, when we have an elevated respiratory rate, is it usually deep and sighing? Or as we move to an elevated respiratory rate, does it tend to become a shorter respiratory cycle, right? In and out, in and out, in and out, in and out. But she's breathing at a tachypnic rate, 26, but it's deep and sighing. And she's a little bit hypotensive at 90/60, just on the edge, right? Just on the edge. I don't have a note to sat. What is that? Crap, right? Do a full set of vitals every single time, everything you need. Even if somebody says, can you recheck somebody's BP? Check them all, right? Because we already talked about that compensatory process. Let's look at our ABGs. Hydrogen, 35. Okay, bottom end of normal. pH, 7.05. Pull my hair out, right? 7.05. Actually, my hair is on fire. PCO2, numbers running together, 11. PCO2, so low. PO2, 187. What? It's supposed to be greater than 80, but 187. And that's those big respirations, right? In and out, deep sighing respirations at a tachypnic rate. She's getting tons of oxygen. She's blowing off all that CO2 with all of that oxygen. Her CO2 is only 11. But look at her pH, 7.05, right? 7.05, oh my God, that's critical. Critical pH, right? Her bicarb, 6, critical bicarb, oh my gosh. Electrolytes, let's look at these. K of 5.3, right? Hair on fire. Critical potassium. Sodium is 141. I don't care about it. Chloride is 96. Okay, so those go, remember I talked about the fine pile. Those go in my fine pile. Fine, fine, fine. I'm looking at what is not fine. So her pH is absolutely not fine. It's in critical range. Her CO2 is absolutely not fine. It's so low. Her PO2 is way high. It's not that that's going to hurt her, but that's an indication of what's going on. And her bicarb is 6, critically low. So what is going on? So here are the questions. Describe her acid-base status. Using the clues you've uncovered here, try to create a clinical picture. We never make a medical diagnosis. It's beyond our scope of practice to make or communicate a medical diagnosis, but we certainly pull together a clinical picture. And other than getting help, what do we need to do? Stat. So let's just take a picture here. Answers. What we've got is severe, partially compensated metabolic acidosis. So take a look at that, right? Severe, partially compensated metabolic acidosis. Let's use these clues to try to create a clinical picture. And I don't want to go through this with you yet because we're going to talk about this a little bit later. And I'm going to use it as a case study later. But I'm going to ask you to take your time and look at those clues and start making a list of signs and symptoms and findings that might be relevant and what you know about them. And then I want you to start making a list that says, other than getting help, get someone in there to help you if you're alone looking after this patient independently. You're in the ER, this is the patient you've got. What do you need to do stat? What does this patient need stat? Now, of course, you're not giving medications without an order, but what are things within your scope that you can do? And also what are you going to prepare for? What does this patient need stat? And we're going to follow up on that. I hope you found this helpful. Gosh, I sure enjoyed our time together as always. No comments that you see me wearing my pajama top again. It's just my my way of saying I love you so much. I don't need to get dressed. And I'll stop clicking on the screen here and I will talk to you all soon. Let me know if this is helping. I love it, but I don't want to love it if you guys aren't loving it. Have a great day. Stay safe, stay warm. It is freezing as I'm recording this. Love you all. Okay, here we go. Bye.